Yes, we can start.
Okay, I will introduce sir. Our next speaker is Dr. Neeraj Gugnani. Uh, Sir has done his MDS from KGMC Lucknow. Presently, sir is working in the Department of Periodontics and Preventive Dentistry, DAV Dental College, Yamunanagar, India. Sir has done the MSc in the clinical trials from the London School of Hygiene and Tropical Medicine, PGCILT, a master degree in higher education from the University of London, MSc in Artificial Intelligence in Healthcare for the University of Alacant, Spain, awarded a Commonwealth Scholarship in 2008 and joined the Dental Health Union University of Massachusetts, UK, Manchester, UK. Sorry. He has delivered a scientific presentation on many international and national platform. He has 90 plus publication to his credit. He is a member of many scientific society like IDR, IPD, ORCA, IDA, ISPPD, and SAPD. Currently, he is serving as an associate editor of International Journal of Pediatric Dentistry and also an editorial board member for Evidence-Based Dentistry Journal. Sir, we welcome you.
Thank you so much. Let me share my screen before I start.
Sure, sir.
Sharing is not turned on, it's saying. If you can
Just a
just.
minute, sir. Just a minute, sir.
Is it visible now?
Yes, sir.
Okay, thank you so much. So, at the very outside, I convey my sincere thanks and gratitude to ISPPD head office and team members of PGIMER Chandigarh, especially Dr. Manoj, Dr. Virender, for inviting me for this rapid revision course. I also convey my greetings from my own dental college, DAV Dental College, Yamunanagar. And today I'm trying to teach students about management of early caries. In the last two lectures, we have learned a lot about caries and minimally invasive dentistry. I'll try to sum up that in a couple of slides, and then we'll shift how can we manage these early caries lesions. So I'll try to cover the topics in these questions, under these questions, because these are the questions which are very frequently asked in the Viva and as short the long answer questions. So what is early caries? How does it represent? What are the stages of early childhood caries? That means how the early caries represents in the primary incisors or the molars, and how to detect these lesions. Can we do something for these lesions? How this treatment effect plan gets affected by caries assessment, and how should we monitor these lesions longitudinally? So let's see these questions one by one. So what is early caries lesions? We know that historically we have been diagnosing or detecting caries at the cavitated stages only, as was told in the previous two lectures. That means we have been teaching, we have been taught since ages that the caries is nothing but a carious tooth. So that's why our treatment strategy for all these cavitated lesions has always been the surgical management. But this has been a historical concept. Today, we are very clear by increased our understanding of our etiopathogenesis of caries that caries is not a cavity. Cavity is the end result of the process by which the caries occurs. So caries starts much earlier than a cavity. So caries starts as a very early white spot demon lesion, and then if we do not intervene in between, if we do not arrest, if we do not reverse that lesion, then very slowly it turns into a cavitated lesions requiring a surgical management. So the contemporary perspective, today's perspective is that caries is not a cavity. Caries starts from very early as a subclinical lesion or initial carious lesion, which leads to a microcavitation, which leads to a cavitated lesion. Then comes broadly, these lesions are divided into non-cavitated and the cavitated lesions. We do have specifically ICDS scoring, as we saw in the previous presentation by Dr. Madhu also. these ICDS scoring system, and we have an integrated ICCMS system, which clearly tells us that for all these non-cavitated lesions, we have to follow our medical management model, that is the non-operative care, and only for the cavitated lesions, we have to follow a surgical care using the principles of minimal invasive dentistry. So these are the two broad aspects as a postgrad students. If the question is asked about the contemporary perspective of caries, broadly classify between non-cavitated and cavitated lesions. Do mention about various classification or the various systems which help us to record these lesions in all these stages, specifically ICDS, and then you can divide into two broad categories of management: non-operative care and surgical care. So in nutshell, till now, early caries are those non-cavitated lesions. Then those can be managed by the non-operative care. So these lesions can be arrested or reversed. So you can broadly explain this using this nutshell definition. So how does it represent? It's important to know that these white early carious lesions represent as white spot lesion. Let's understand why it appear as a white opacities. First of all, on the topmost layer, the surface is intact surface. So the porosity in the outermost surface is less than 5%, but in the subsurface it is more than 25%. Why it happens? Because most of us are actually using a fluoridated toothpaste. So no doubt the demon will start from the top, but outermost layers also start getting remineralized because of the presence of fluoride. So the outermost surface becomes a pseudo intact surface layer, and but just beneath that, the pores don't get so much easily remineralized. That's why the pseudo intact surfaces layer is intact still. So this is the primary reason it is recommended that you should not use a sharp probe, otherwise this pseudo intact surface layer can break, and a non-cavitated lesion can become cavitated because of your inadvertent pressure provided by the sharp probe. So because of this porosities in the subsurface lesion, there is altered light scattering. You can see that if the refractive index of sound enamel is 1.62, but the refractive index of water, which because of the pores, these pores will be now filled with the water, and there is a difference between refractive index of sound enamel and water. So you are able to see the white opacity. If you dry the lesion, then the water will go away, and now the pores will be filled with air. Now the refractive index of the air and the sound enamel is even further apart. So that's why on drying the lesion, these white opacities become more accentuated. This is one of the tests also to differentiate between the lesions of caries and because of fluorosis or other developmental lesions, that when we dry the lesion, if the lesion become accentuated, that simply means that the water is going away and those pores are getting filled with air. That's why these white opacities appear. So these lesions appear as white spot lesions or subsurface demineralizations, and these are the lesions for which you have to intervene. Otherwise, they will lead to cavitation. So we need to understand this is the stage when we should actually consider it as a clinical clinical caries. It's not a cavity; it's a clinical caries, visible clinical caries. Clear? So this is the classical progression of a cavity, and as you can see, the green arrow, the lesion becomes visible much before the lesion is cavity. So cavity clinically detectable is much after the lesion is clinically visible. The lesion is visible as a white spot lesion, maybe on the occlusal surface or maybe on the facial surface. And in the proximal surface, if you take a X-ray and if you find radiolucency, you need to check whether it is cavitated or not, because there are lesions which are still not cavitated, but they would represent as a radiolucent area between the two proximal zones of the tooth. So in nutshell, early caries are clinically detectable as white spot lesions. There is a pseudo-intact surface layer due to which a sharp probe should never be used. So now comes stages of early childhood caries. Lift the lip. So till now we have understood how in general caries happens, and we know that in cases of early childhood caries, we have four stages of caries: initial, damage, advanced, and severe. And as you can see in the first column, the initial stage is that chalky wout spot regions near the gingival margins, which are also called as non-cavitated enamel. Clear? And there is a specific procedure called as lift the lip. That means we can teach the pediatricians, we can teach the para health workers, we can teach the parents that they need to just lift the lip, and if they find any white opacity, we have now understood this white opacity is because of the difference in the refractive index of the sound tooth and the porous enamel. So if they are able to see these, this is the earliest sign of early decay. This is the stage when the parent should bring the child to us. Otherwise, these are the lesions. If not treated, if not managed in time, they become damaged, they become advanced or severe. So they will only lead to further cavitated stages. But this is the stage when we as a dentist, we can intervene. So if the question is asked, you need to explain the process a bit, like like a circular diagram, and then you can shift why the importance of detecting the lesions at the chalky white spot lesions, that is the initial lesions. And this is the lift the lip is the procedure by which we can train the para health workers and the parents also to detect this early stages even at home. So how to detect and record these lesions? I mean, how to detect and record these lesions in the clinic. As we have seen in the previous seminars, I will not go into detail of this. We can have ICDS scoring pattern. It is mandatory, I would say, for all the postgrad students to learn and retain ICDS scoring, because it is the only system that allow recording of caries in its complete spectrum. There are modern detection tools also like QLF, FOTI, Diagnodent. I'll not go into detail of this. There are many AI portals are also coming, and there is a specific portal for ECC detection by University of Rochester. You can just Google that and you can find a link to that AI portal. So we have modern technological tools, but the most validated, most easy system, most recommended is the ICDS system. And you should remember that these adjunctive tools support, but they do not replace the clinical examination. So because of the scientific and the histological validation, I still recommend everyone to read ICDS in detail. If any one of you want to learn the ICDS, just go on the portal of ICCMS and there is a e-learning tool about ICDS. You go through the whole scoring system, then they will take a test and then they provide you a certificate. Clear? So the next is, can we do something for these lesions? That is, what are the treatment strategies? So if we want to understand what are the treatment strategies, we should read this article, when to intervene in the caries process. What does it mean? That no doubt the caries starts from early white spot lesion and the end result is cavitation, that is the deep cavity involving the pulp, ICDS stage 6. But when we should intervene? So should we intervene only when the caries is cavitated? Yes, if the caries is cavitated, we can intervene, but that means we have to drill and fill. No doubt we will be using a minimal invasive dentistry approach, but actually we should not be waiting for a white spot lesion to become a cavity and then intervene. That we have been doing historically and even sometimes nowadays. Ideally, we should be recording the lesions in the early stages and start our active intervention at that stage. So that is the crux of this seminar. Clear? So broadly, as per this article, there are three strategies: non-invasive, micro-invasive, and minimally invasive for cavitated lesions. I will just try to cover the first two strategies, non-invasive and micro-invasive. So as this table depicts, non-invasive means no tooth removal. So we will not remove the tooth at all. So it does not involve any use of burr. It does not involve use of any spoon excavator, nor even the etching. So we are not removing the tooth at all. In micro-invasive, we will be using some kind of etching because it will involve removal of the some minerals still, but to the micrometer level. That's why it's called as a micro-invasive. Minimally invasive is mainly for the cavitated lesions that we will not deal with today. So non-invasive means oral environment change, use of fluorides, and use of non-fluoride topical remin agents. NAFTA means non-fluoride topical remin agents. So these are the three broad categories. Micro-invasive, use of sealants and resin infiltration. These are the two strategies in which we actually use sealant, actually use etchant, and the etchant will lead to some kind of demineralization, but to the micrometer level. So we are not using any spoon excavator. We are not doing any gross excavation, no burr. So that's why it's called as a micro-invasive strategy. So let's see them one by one. So coming to the oral environment change, changing the oral environment. So if a question comes, about ECC early caries management, just broadly explain there are two strategies: non-invasive and micro-invasive. Under the non-invasive, explain that there are three main categories: changing the oral environment, use of fluorides, and use of naphtras, that is a non-fluoride. And then we will see what comes under the micro-invasive. So changing the oral environment. The first thing is brushing. As we all know, brushing is primarily indicated or primarily talked about prevention of caries. But of course, in a patient who is actually not brushing, this becomes a risk factor. So that's why it also helps to reverse the lesions or arrest the lesions. So it is strongly recommended to brush at least twice daily for 2 minutes. Use of a fluoridated toothpaste with a minimum concentration of 1000 ppm. And we all know this diagram, that how to make the alteration in the amount of toothpaste and not in the amount of fluoride in the toothpaste. So using the smear layer to the pea size to 3/4 of the bristle length, and then the full length as per the ages. So children should spit out, not swallow, and not rinse. This is mainly because if they try to rinse, or if they try to use the water, then the extra amount of fluoride can be ingested, leading to some disadvantages. So it's recommended that they should spit out, or the parent should guide them to remove the complete toothpaste. Clear? Diet modification, we all know that three factors regarding the diet, regarding the cariogenic diet, which includes the carbohydrates, is important: frequency, consistency, and time of clearance. Uh, and as a clinician, you can use food diaries, that is the 3 to 5 day diet diary, or apps to determine about diet modification, which can be taught to the patients. The third is the use of fluorides. As I told you, no doubt fluoride is the pivot of caries prevention, but the same can also be used to promote the remineralization. So, as we are not talking of prevention now, we are talking of management of early carious lesions. So, in the non-invasive care, fluoride makes one of the prime pivotal role, because it also promotes the remineralization. So, we know that fluoride at home, with the help of dentifrices, is mainly for prevention. No doubt it will also help in the remineralization. But of course, if the child is a medium or the high risk, we can recommend use of professional topical fluorides also, which includes gels, which includes varnishes and solutions. In the exam, you can write in detail about the concentration of gels, the concentration of varnishes, why varnishes should be preferred in young children, and no doubt the use of home fluorides in the dentifrice is for everyone, but use of topical fluorides is to be individualized according to risk. These are the different strategies shown in the bottom, different diagrams. What are the different applicator tips or the form trays available, how we can apply it to the patients. Next is the non-fluoride remin agent. So we are talking of non-invasive methods. In the non-invasive, first was the brushing, second was the diet, third was the fluoride, and fourth is the naphtras. So we know that these are the calcium and phosphate based strategies. For any remineralization to occur, no doubt in the presence of fluoride, that reaction is very fast, but only and only the remin will occur if the saliva is super saturated with calcium and phosphate. So it makes wise for specifically for the high risk patients to increase the bioavailability of calcium and phosphate ions in the saliva. The the evidence about the use of fluoride is much higher than the naphtras. So no doubt naphtras are indicated, but only in case of high risk patients. So these are the three commercial toothpaste available in India, which includes Tooth Mousse Plus, or Clean Pro Tooth Cream. They are recommended for medium and high risk. Toothmousse Plus, Clean Pro Tooth Cream, and Toothmousse, they are recommended along with the use of fluoride. So you can see in the Toothmousse Plus, the fluoride is already there. In the Clean Pro, the name is functionalized tricalcium phosphate. It also has a fluoride up to 950 ppm, because there is a synergistic action between these and the fluoride. Fluoride acts as a catalyst to promote the reaction or the action towards the remineralization. So we know that these calcium and phosphate based strategies are helpful, but definitely they will work better in the presence of fluoride. So as you can see in this diagram, which shows an example of, this is from one of the theses done in our department. As you can see from the top to the bottom, there are cervical whites opacities available that are seen After 3 months, you can see these white opacity is decreased, and 6 months again there are almost no. The green images are the QLF images taken for the same teeth. So these are the other non-fluoride topical reamine agents. If a long question comes, you can just explain these also, like Curodont, like with the help of peptides. You know that Recaldent is available, Clinpro is available, Ora-Vive is available, that is calcium sodium phosphosilicate toothpaste, and some more toothpaste like Enamelon technology, which has a polyphosphate systems. So these are the different NAFTA systems which are available. Now comes the antimicrobials. No doubt they play only adjunctive role, and evidence remains limited. But still, they are as per the high risk, for the high risk patients, they are indicated. They aim at reduction in the bacterial counts. They are also available as varnishes, gels, and rinses. A combination of Cravitec plus antimicrobial toothpaste, which has chlorhexidine along with fluoride therapy, is very helpful. The other antimicrobials include povidone and xylitol. So these are the 5 non-invasive strategies. Coming to the micro-invasive strategies, I told you micro-invasive strategies simply means that we will apply some agent that will lead to a removal of minerals from the hydroxyapatite, at least to the micrometer level. So the first strategy is resin infiltration. This is a technique to arrest the lesion. There are 3 steps: agent application, drying, and the infiltrant, that is the resin. So it has 3 syringes within the system, within the kit. First is the Icon H, which is nothing but the 15% hydrochloric acid, then the alcohol as a drying agent, and then the infiltrant, which is nothing but a very high flowing resin. So as you can see in the diagram, it works on the principles of capillary action. We will try to accentuate those pores, and within those pores, the low viscosity or the high flow infiltrant will go deep inside. So the indications can be white spot lesions, that is early caries, which may be on the proximal sides, on the facial sides like the cervical zones, or post-orthodontic any. It also improves the aesthetics for other white opacities, but I will not discuss like fluorosis and other. I will not discuss that. It is important to understand that the primary use of resin infiltration is to stop the early caries. But in addition to that, one advantage, one beautiful advantage is that because the refractive index of the infiltrant is quite close to the sound enamel, it also leads to aesthetic change. So no doubt, RI was brought to the market for stopping the progression of early caries. That's why it is recommended to arrest the early caries as such, because the pores get infiltrated by the infiltrant, and that's why the bacteria which stays inside, they don't get any food, they die off, and then the caries doesn't progress. Clear? So these are the 2 or 3 clinical cases. As you can see, white opacities after the orthodontic treatment, which can be easily managed by resin infiltration within few minutes. This is a case which is also published. It is a primary incisors showing the white opacities, and with the help of resin infiltration, you can easily achieve aesthetic improvement, also the arrest of caries. So no doubt, these lesions sometimes can also be managed by non-invasive care, but during that process of long non-invasive non-invasive interventions, these lesions may take exogenous stains and may become brown in color. So that's why whenever you see a patient who is not very compliant, it's better to use resin infiltration to have immediate aesthetic improvement. Again, the primary intention has been to stop the progression of the early carious lesion. Now, second strategy is use of dental sealants. As we all know, the dental sealants are primarily used for prevent caries, but they are also used to arrest caries. So any time when you see a occlusal surface which you feel is cavitated or is not cavitated from the surface, but the X-ray shows radiolucency, or there is a microcavitation, we can use dental sealants. So even when the X-ray shows that the caries is extending to the E2, that means the deeper enamel, or even the outer dentine stages, but the surface is not cavitated, it is recommended to use a dental sealant. So for ICDS 1 and 2 lesions, when the non-cavitated occlusal lesions are there, you can simply seal the surface. The same principle is used when we restore a primary tooth by the Hall technique, that we just seal the area so that bacteria don't grow, and that's why the caries progression will stop. But when there is already a cavitation, then this process directly will not be used. So for microcavitations, you have to use a PRR technique, and for a cavitated lesion, you have to use some minimal invasive strategy. Use of dental sealants is mainly for those non-cavitated lesions which show radiolucences to E2 or D1 stage, but the surface is not cavitated. That's very, very important. Clear? Now, caries risk assessment. Will it affect my treatment plan for these lesions? This is very, very important for postgrads to understand. Conventionally, over the years, we have thought, or we just conceptualized, that whenever we see early caries lesions, the treatment is fluoride, the treatment is RI, the treatment is something non-invasive or micro-invasive. No, it's important for us to understand that the treatment is actually based on the caries risk assessment. As you can see in this diagram, see the first steps. First step is assess the risk. So the flowchart given by the ICCMS doesn't jump directly to the treatments modalities. It asks us to assess the risk. Only and only if the risk is moderate or high, we have to manage these early carious lesions. You have to focus this thing in your answer sheet or in the viva. The early carious not cavitated non-cavitated lesions or the white spot lesions don't require any professional care if the risk of the patient is low. That simply means that the conventional strategies would regress or remineralize the lesions. So we don't require any aggressive strategies if the risk is low. As you can see, as per the risk, there are three strategies, and in the low risk, you can see they just say use a fluoride toothpaste, healthy diet, routine dental checkup, monitor only. So no additional non-operative therapy. Only in the moderate risk, they say we have to go for additional therapy, and of course, in the high risk also they add SDF also. So be very clear that treatment of ECC or the treatment of early white spot lesions is not directly fluoride or non-operative or micro-invasive care. The treatment of early white spot lesion depends upon the risk assessment. Risk assessment, low, moderate, and high. Only moderate and high would require some kind of specific professional care. Low risk, no doubt, you have to monitor those patients because you want to those lesions to remineralize, and you want to see that the white opacities are now getting away and the tooth is getting remineralized. If the remin is not occurring, then you have to definitely shift towards more professional strategies. This is another chart given by the APD, American Dental Association. As you can see, this red circle that I have made, it clearly says that to arrest or reverse non-cavitated carious lesions, you can use sealants, sodium fluoride varnish, APF gel. Then how to use on the proximal surfaces, resin infiltration, use of sealants, fluorides. So as you can see, the strategies are broadly non-invasive and micro-invasive, but the use would depend only when you have done the risk assessment profile of the child. This is the same text that I've just shown you, but in the form of a flow chart. If any one of you is interested, this is the beautiful article. You can just go on the evidence-based clinical practice guidelines for non-operative care for carious lesions, and there are similar chart is also available. So in this, you can see it is categorized into occlusal surface, facial surface, and proximal surface. For non-cavitated, it has shown sealants alone, sealants. So non-cavitated so and so, cavitated so and so. Similar chart is also available for the permanent teeth. So I'm not going to into detail of this permanent teeth. So let's leads to me the last question. Should we longitudinally monitor these lesions? It's, as I told you, these are the early white spot lesions. These are the lesions which will become cavitated if we do not intervene. But even if we intervene, if we don't monitor these lesions, how will we know that those lesions are getting remineralized? So it is very important that we recall the patients. These are the three strategies as per the evidence, that when we should recall for all the low risk patients every 6 months, for all the high risk patients every 3 months, and for medium risk every 3 to 6 months. Again, coming to this diagram, this was the stage lesion visibly clinically as a white spot lesion. If on the recall you see that these lesions are getting more accentuated and not the white opacities are not improving, then that is the stage when you should conceive that this lesion will become a cavitated, and your strategy to remineralize should become more aggressive in nature. Clear? So whenever you recall the patient, you should have an objective structured program in your mind. How will you evaluate the patient? So again, coming to all the seven factors that we discussed about non-invasive and micro-invasive strategies, check about brushing and diet strategy, check the sealants that you might have given, whether they're intact or not, check the need of fluorides, because a patient from a low risk can move to a medium or a high risk, or a patient from a medium risk can move to a low risk. So you need to reassess the need, whether this particular patient requires professional care or not. Remin products, antimicrobials, and recalling the patient again. So that should be the strategy for us. And definitely check for any new lesions, whether cavitated or early white spot lesions. Clear? So whenever there is a cavitated lesions, as Dr. Kalpana told in the last lecture, we should follow the minimal invasive dentistry principles by excavating as less as possible using different strategies which are available as evidence based. So from the exam point of view, I'll just try to read a few lines for you and you can just focus on those. Clear? So on this topic in the MDS examination, you may be asked, questions may be asked either as a short note, such as early caries management, use of fluoride in caries management, resin infiltration, antimicrobials, etc. But a question may also be asked as a long or essay question, for example, contemporary management of dental caries. In such long questions, you are expected to discuss complete approach, including diagnosis, detection strategies, modern detection tools, treatment planning, caries risk assessment, strategies for early caries management, and including the deep caries management strategies. So this is a very important topic, caries management, and you should make a complete story out of that, which should be as per the evidence, and you should also quote different evidence guidelines or very important some of the good papers also. Viva questions from these topics are also commonly asked. Beyond postgrad examinations, also early caries management is extremely important in day-to-day clinical practice, particularly in medium and high caries risk children. Believe me, this is a approach that can be monetized once you start the practice. These are the patients you will encounter throughout your professional career as pediatric dentist. If you don't follow the approach of micro-invasive and non-invasive strategies, the patients would not come back, because then the recall would not be a very emphasized strategy from your side. Even if you recall a patient, if you don't have an objective structured framework with you, the patient would not understand the importance of that recall, and the patient would have a newer lesions and may lose the faith in you. So that's why it's important for you to understand this topic and make a complete note about these things in your examination also. So always follow ICCM approach, ICCMS. Why I'm saying that? Because this is the best, most evidence-based guidelines approach, and this is recommended by the caries research organization all over the world. It helps you to deliver evidence-based and patient-centered care. With these words, I just wish you best wishes for your examination, and I'll be happy if there are any questions. I'll try to help them with. Thank you so much. Thank you, Dr. Manoj. Thanks everyone from the PGI and the ISPPD head office. Thank you.
Excellent presentation.
Thank
You
you.
have simplified the high-yielding concept of the postgraduate curriculum beautifully. So there are a few questions. One I can see is, does resin infiltration is available in India? So I think the answer is yes.
Yes, now it is available. There were a couple of months when it was not available.
Thank you.
Sorry, somebody is unmute.
What is the management strategy for non-cavitated proximal lesions? The only strategy, see, we have proximal sealants also available, but proximal sealants are not very frequently used. So for any proximal lesion, we have only two strategies. Number one, you have to take a IOP X-ray. If that IOP X-ray shows radiolucency, check for the cavitation status. If the lesion is cavitated, you have to make a cavity as per the MID approaches. If the lesion is not cavitated, there are only two approaches. Either the use of proximal sealants, which are available worldwide, but in India, They are very less used. That's why very less available. 3M company makes a proximal sealant. The other strategy is use of resin infiltration, which is there are two different kits. As I told you, 3 syringes are available. The 3 syringes are the same both for the facial lesions as well as the proximal lesions. Only difference is in the applicator tip. For the proximal lesions, the applicator tip is a kind of a mylar strip, so it easily adapts between the proximal areas between the two teeth, and it can be used to follow all the 3 steps. That is the etchant, second is the alcohol for the drying, and third is the application of infiltrant. So again, I just recommend the two things: proximal sealants and resin infiltration.
So Dr. Wajid has raised his hand, but I'm not sure he wants to ask a question or something else. Dr. Wajid?
If there are any question, you can just speak out or
Yes.
just write in the chat box. I have opened the chat box so I can see directly from there.
Oh, yes. I think there are no more questions. Can we go to certificate, sir? Uh, Sir, you have to stop sharing your
Okay.
screen.
Screen I already stopped.
Okay, just a minute, sir. Sir, please
Thank you
accept
so
this
much.
token of appreciation from
Thank you
sir.
so
Next,
much.
thank you, sir. Thank you, sir. Thanks a lot, sir. Now moving towards our next speaker. Can we have a next slide, please? Yeah. Uh, our next speaker is Professor Surendra Baliga, sir. Professor Surendra Baliga, sir, serves as a chief dentist at Amber Dental Center, Bangalore, and formerly held a prestigious position of dean. He completed the graduation from A.V. Shetty Institute and earned a pediatric dentistry master from Menapur Dental College. Beginning at the Manipal Dental Sciences, he later completed PhD focusing on the sickle cell anemia among the tribal children population. He is a fellow of Royal College and advanced fellowship in dental education and pediatric orthodontic, strengthening the expertise. He serves as associate editor-in-chief of ISPPD Journal, published over 150 scientific paper and leading conferences. Currently, ISPPD president. His interests include phytodentistry, minimal invasive dentistry, advancing pediatric dental research, education, and practices. We welcome you, sir. Can we have the sir's recording?
Everyone. The post-lunch session, I have been assigned the topic of stainless steel crowns with false spectrum. I'll try my level best to make it interesting as much as possible. Well, I begin my lecture with a quote: "If all your energies are focused in one direction, enlightenment is not far away. After all, what you are seeking is already within you." I have taken reference from all the basic textbooks, both of Indian origin and international origin, and I've tried my level best to put in all these things with the journals also. And I've tried to incorporate all those things which are pertaining to stainless steel crown into my lecture. The basic content, introduction, classification, what is the composition, indication, case selection, armamentarium, clinical procedure, modification, complications, and conclusion, and along with it, I've added a component of false technique also. Because nowadays you don't know, when theoretical perspective, you might get a question on stainless steel crown or the Hall's technique, either as a short note or as an essay. Well, just to give you a formal introduction about stainless steel crown, 1947, when we got independence, preform crowns were introduced by Rocky Mountain Company. In 1950, it was stainless steel, which was described by Angel, and once that was introduced, then it was popularized by William Humphrey, who introduced it to pediatric dentists. So it was Angel who found stainless steel crown, and then popularized by William Humphrey. We've all read a lot of classifications also, and which is important, because at the end of the day, when it comes to theoretical perspective, if a question definitely you should be knowing. Even from the chairside viva perspective, all this becomes very important. So we have classified it according to 3 types: according to trimming, according to the occlusal anatomy, and according to the composition. I just put in a picture according to the trimming. Untrimmed it was introduced earlier on. There was a lot of trimming to be done. It had a long body. So this was introduced by Rocky Mount. Then it became pre-trimmed and pre-festooned by Unitech. And lastly, we got 3M who introduced the pre-trimmed, pre-festoon and the pre-contoured crowns. Now, according to the occlusal anatomy, initially occlusally it was very small, which was introduced by Rocky Mountain. Smallest and least occlusally carved. Compact occlusal anatomy, Icon. Shallow occlusal anatomy, Unitech. And now we have beautifully ideal occlusal anatomy by all the companies like 3M or less so many Indian companies. It's wonderful to have. It's a privilege for all the students to work with today's stainless steel crowns. Now, according to composition, stainless steel crown, simple, 17 to 19% chromium. Most of the time it's asked in the Viva perspective. 10 to 13% nickel, 67% iron, and remaining are minor elements. Nickel-based crowns, 72% nickel, 14% chromium, 6 to 10% iron, 0.4% carbon, 0.04% carbon, 0.35% manganese, and 0.2% silicon. So this is based on, most of the time these are asked from the Viva perspective. Now, what are the indications? Which is very important for all the students to know, because we see a lot of posts on Instagram nowadays. If a simple class 2 is also there, people tend to go for a stainless steel crown, thinking that that's the end result. I believe I have the perspective that we should give importance to the small tooth and give importance to the tooth structure. So these are primary indications which are universally given, which is immediately after pulp therapy, a restoration of multi-surface decay, which has to be understood. Patients who are at high risk, primary teeth with developmental defects, where amalgam is likely to fail, teeth with extensive wear, fractured cusp, or as an abutment for space maintenance. Indications for use, permanent molar teeth, definitely it is indicated. Teeth with developmental defects, restoration of a permanent molar which requires full coverage, but it is partially erupted, because you can adjust the tooth accordingly, crown accordingly. Then interim restoration of a broken down or a traumatized tooth. So this is just for instance that indications are separate for primary, and for permanent also we tend to use it as the tooth is in the still phase of active eruption. Steps in stainless steel crown preparation. Most important, case selection. Once that's done, the procedure remains same. Armamentarium, selection of crown, tooth preparation, crown adaptation, crown finishing, and lastly, cementation of the crown. Now, coming to the case selection, I always felt that students, when in the phase of completing the quota and hurry, they always tend to do things in a more faster way, or might be go through the shortcuts. So I still feel that giving importance, as I mentioned earlier, to the natural structure. So expecting there should be a good gap between it might be permanent or primary. Giving emphasis to the enamel is the primary criteria of any pediatric dentist. I always believe that we're talking about minimal intervention dentistry. So obviously, when we do such kind of crown preparation, kindly make it a point that if there is a good crown clearance, then it becomes very easy. So whenever you do, especially a post-endo restoration, then make sure that whenever you have, before restoration only, you can just slightly trim it off so that you have good visibility of the proximal surfaces. Core buildup, and this is very important. Proper core buildup should be done. As I mentioned, once you trim it off, you just break the contact when it's visible. Then you can do a core buildup. Status of adjacent erupting teeth also should be considered, especially when you prepare on ease. Now, placement of separators, as I mentioned, it's always good, because you tend to have a gap between the tooth which has to be cut and the adjacent tooth. So it automatically gives you a better access, and don't always, as I mentioned, reduce the risk of hydrogen damage to adjacent. It also helps to depress the gingival tissue and the rubber dam. So these are some advantages when you do it. So once you know the case selection, now we go for once you know that the case is selected, now next step is crown selection. Now we have to, because these are all preformed crowns in various companies which have come up. So we need to know the mesiodistal width of the tooth which we are going to prepare the crowns. We use a divider. We use a Bolli's gauge, we use a vernier calipers, or might be trial and error. My personal opinion, to a certain extent, which we have learned, is that whenever we are preparing a tooth, so if suppose you are planning to use E4, then always have E3 and E5 with you for any purpose. Sometimes if there is a deviation, then you are ready with these three crowns. It should be there in the operatory so that if one size is here or there, then you can use it. So always make it a point that all these three crowns are available in the practice. Now, other factors to be considered, definitely check the occlusal anatomy. Nowadays, we don't have to worry so much because they're all with good anatomy, height is matched, pre-contoured, pre-trimmed, and give emphasis to areas of primate spaces. If there is availability, please leave the space because the whole object, you can't expect that you give a good crown covering entire crowns. So give emphasis to the natural spaces which are available in the child. Now, tooth preparation, simple. Rubber dam kit, if possible. Local anesthesia, definitely. You should make it a point that you give either infiltration so that the patient is convenient, and the burrs. The problem in burrs also, I have seen students using the same burr for the whole year. So you are unnecessarily causing an iatrogenic damage to the tooth which you are going to cut. And this happens in general. Always, which I see is in all the patients, or even a class 1, class 2 cavity, use the same burr. So you are causing damage to the tooth. So please refrain from using burrs for years together. Maximum you can use up to 6 to 7 cases might be quality burr. And the process for the dentist or pediatric dentist becomes easier with newer burrs because the cutting is faster and you can achieve the results for placement of the crown. Now, occlusal direction, burr use 330. Various people have suggested various, the thickness. They have said that Matthewson has said it's 1 to 1.5 millimeter. Troutman and Kennedy told 1.5 to 2 millimeter. Rapp has said 4 millimeter from the gingival margins, but we stick on to it that we use up to 1 to 1.5 millimeter so that amount of visibility is there between the upper and the lower teeth. Now, for proper occlusal reduction, I use it in my practice called prep gauge, or these prep gauge are like, they are boomerang shaped. These are silicon gauges which are present. So there are variety 1 millimeter, 1.5 to 2.5. So all the gauges are available. You just have to keep it and check the gauge, and then you can see whether the gauge passes through, and that's wonderful. You can measure it, which becomes easier. Now, what are the possibilities? Determination of gauge pulled out from the buccal aspect with minimal resistance, adequate preparation of the tooth. Gauge cannot be pulled up, then you can expect inadequate reduction. Gauge be pulled out without, then over reduced. So you should make sure that if it's slightly more also it's okay, but if it's lesser, then it becomes difficult for placement of the crown. Now, coming to proximal reduction, use burrs 169L burr, or sometimes, that's very important for mesial reduction. I have seen mesial reduction people take a burr, any burr which is available, just use it. There are definite burrs which are used for proximal reduction. Please use only those respective burrs meant for that purpose. Give a knife edge finish lines. That is what is expected in a primary tooth preparation. Whenever you're preparing it for a stainless steel crown, you don't have to worry because you don't require any kind of a chamfer or any kind of a preparation. Margins are simple. You give a knife edge finish lines, keep it happy, take a TC21 or EF or TC11 EF. Just make sure that you remove all the overhanging enamel which is there, and that's it. Then your preparation is done. You're finishing the surfaces. Occlusal or proximal first, this was always a debating portion, but I always felt that occlusal is easier because if you have to cut the proximal, your visibility should be more. If you have not placed any kind of separators, it becomes a headache. So you as well reduce 1.5 millimeter the occlusal and then it becomes easier. Though Full et al. Consider preparing the occlusal surface first, which because follows better access to the proximal areas. Some people have told, but again, clinically, it's always the occlusal first and later on the proximal side. Now, buccal and lingual reduction, is there a requirement? These are natural undercut retentions, really helps it out because you have a buccal bulge in the upper and in the lower, and in the upper you have a lingual bulge which acts as a natural undercut. If the buccal bulge is large, then we slightly reduce the any time of any large reduction, buccal or lingual bulge, we slightly reduce the bulge which is considered. Now coming to the finishing, once you prepare the occlusal, the proximal, and then if any of buccal and lingual any reduction is there, then you need to finish it. I have already told, use a TC21 or 11 or 20, again 21, or so you EX21. So now what you're supposed to do, you are going to round off all the lined angles, because otherwise in that area you will end up in having problems. So you will prevent concentration. So which are the pliers for crown adaptation? Now I have reduced my tooth. I have given an ideal reduction. Now what are the pliers for crown adaptation? See, we use scissors because we need to. Now we start looking at the crown. We have selected the crown. As I tell you, we have 3 crowns. So we use to cut excess material. Then we have Johnson's contouring plier for crown contouring. Then we have the crimping plier for crimping of the cervical third, and the straight hoe plier for flattening of the contacts. So what we do, once we place the crown, we made a scratch at the level of the free gingival margin as an aid to determine the additional metal. So you should know, once I place it, free flowing, the crown goes inside. It should not have a lot of resistance. It goes inside. Then you place it. So once that is done, the excess material is just cut off with the scissor. So we keep it around 1 millimeter below the marked line. We cut the metal with the scissor, and buccal and lingual surface. Once that is done, buccal and lingual surface, we take a contouring plier and contour it. The crown which is held with the plier, and the pressure is exerted with the finger from the opposite side of the crown to bend the surface inward. So the contouring plier, if you ask me, is walk through, directing all margins inward along flowing contour. So you just hold it and inward so that the contour is maintained. Now what is crown clipping? Once the contouring is done, then we finish it. Then we look at what exactly needs to be contoured. So if you look at the contouring, when crown contouring pliers, once the contouring is done, so what is important to remember is the finish lines, especially in the proximal side, they have to be finished in that is where the secret lies. So you are contouring, finishing the proximal sides, and then once you feel that this fit is stable, there's no blanching, then you take the crimping plier and just at the cervical third, pinch it in such a way that the handle of the pliers are tipped inside to the center of the crown, so that the metal is stretched and the curled inward, and the crown gets a grip and this grip sits on to the tooth, and which gives us maximum amount of retention for the. So coming on to the finishing of the crowns. Now, once we know that there is going to be some kind of a term, the crown is when you're trimming it, you use a stone, so definitely there's going to be some scratches, and there'll be sharp edges. So usually crown length is custom cut with large abrasive wheel. Heatless, we use something like a green stone, which is rotating in counterclockwise direction to achieve knife edge finish. Now crown surfaces are smoothened, preferably with a rubber wheel, and final finishing with a cloth, or you have this Gamos wheel on dental lathe which we use, which if it's available in the clinical practice. Otherwise, clean it up using you just rub it with the triple polishing agent or jewel. You have this iron oxide where this for silver polishing they use it it's called a jeweler's robe, which is recommended. So see, these are the procedure standard. Ethically, when we directly place it up, but definitely these are some procedures which we need to do to get a very aesthetic appearance of the crown in the mouth. Now, what are certain things which are important to note? Make the tooth preparation to fit the crown form. Do not meddle with the crown so as to fit the tooth preparation. Gingival contours to be considered during preparation, especially for the molars, the primary molars. If you look at the gingival contours are a little different. Seating of the crown from buccal to lingual, because buccal bulge is there. If you look at the buccal bulge for the lower, which is there on the buccal, so you place from lingual to buccal. For the upper one, we place from buccal to lingual, since there's a lingual bulge. Trimming procedure should be carried away from the patient's face, because the stainless steel fragments keep falling. So make sure that the patient is wearing a protective eyewear so that nothing flies when you're doing it, to make sure that because this is something which you need to, it is very important because it keeps flying away, and have a snap or a snugly fit under finger pressure. So these are things which you have to make sure that the patient, you follow when you are doing a stainless steel crown on a patient. Way back, Spedding has given two principles for marginal adaptation, that is in 1984, just for reference, though so many things have now changed. But of course, these are certain things which we sometimes, the viva perspective, we ask. Principle one, when primary molars are viewed from either proximal surface, buccal or lingual surface, converge occlusally from the gingival crest. Because the stainless steel crane that does not adhere to the morphologic features of primary teeth will be overextended and ill adapted. So this is both principles for only for marginal adaptation. The second, examine the contours of the buccal and lingual gingival margin before a tooth is prepared for the stainless steel crown. Produce SSC margins, that is stainless steel crown of similar shapes. When these margins are adapted circumferentially against the tooth surface, just apical to the greatest diameter of the tooth, they will be located at the correct anatomic positions at all points on the tooth. So if you see, these are two basic principles that Spedding has given, which we follow even now to a certain extent. They say you place the trim crown, untrimmed crown, put an explorer, mark it, just cut it in a straight line, remove the excess metal. All those things we follow even today. Now, final cementation of the crown. So how much amount of gluting to be taken? So this is also an empty. So usually we take around 2/3 or half of the luting cement onto the crown, and we definitely make sure that once it is placed, we remove the excess and definitely floss the area. Now there are so many studies on stainless steel crown and luting cements from way back 2006 to 2017, so on and so forth. So many studies have done. But still, it is said that there's a wonderful article of User Stainless Steel Crown Systematic Literature in 2014, which said that RMGIC would be a good material of luting for stainless steel crown against the primary tooth. Now, coming to what are the modifications in placement, all of you have read this, but of course, you should know when we should do it. Whenever there's an adjacent stainless steel crown, adjacent with class 2 restorations, with arch length loss, before eruption of permanent molars, crown extension for deep gingival caries, open face stainless steel crowns, opposing supraeruptive teeth, and restoration of hypoplastic teeth as well as bruxism. Now, whenever we talk about modification of stainless steel crown, undersized, oversized teeth, open contacts, these are certain areas which we work out on. Whenever there's an adjacent stainless steel crown, as I mentioned, make sure you cut both the teeth together. Don't place one, and because between supposedly you're cutting on D and D, then we have to slightly cut the distal of D and mesial of E a little bit more so that it can accommodate, and you with a straight hoe make sure that the areas are a little bit compressed so that they sit in the best possible way. So make sure adjacent proximal surface should not slightly reduce more than usual. This is fundamental when it comes to when two teeth are getting stainless steel crown placed. If there's a crown which needs to be placed adjacent to the class 2 restoration, make sure stainless steel crown is done first, later class 2 restoration at the same time. But it's like you do it and then you do a class 2 preparation to allow proper contour. Now coming to adjacent stainless steel crowns, arch length loss, because since there's a loss of already mesodistal dimension, additional reduction of proximal surfaces might be required, and a smaller size crown might be preferred because the space is less, so you definitely go for smaller stainless steel crowns. If there is before eruption of the permanent molar, care for the space needed for the eruption of the permanent molar, definitely consider that. Don't keep the marginal ridge a bit flat so that it's helpful. Crown extension, whenever there's crown extension for deep subgingival caries, crown margin should be overextended. You can slightly weld it or solder it so that the metal piece goes along to the crown. Alternatively, otherwise, if you have, now very rare, but otherwise if you have mountain or unfestooned crown, they can also be used. Open face, very rare again, where we tend to modification of anterior tooth, labial surface is trimmed away and we place a resin based on it, and then we fix up, we do a veneering with the crown and place it on the crowns. Restoration of hypoplastic teeth, hypoocclusal wear, decreased vertical height, definitely. So we sometimes when we do this, we layer a layer of solder from the impression surface material so that some amount of height is provided. In cases of bruxism, we give stainless steel crown. Don't give any zirconia and all. Check the patient because sometimes the zirconia is very hard. However, stainless steel crown is more, it just wears off. So it's easier. Pre-veneer stainless steel crown, again, as I told, is because of the improved aesthetic quality. Undersized crown or oversized teeth, yeah, this is again, we do a cut the stainless steel crown a smaller size and we directly split it into a V and we try to paste an additional stainless steel band of 0.004 onto the welded place so that you have a more occluse the labial margin and it seats perfectly onto the primary tooth. If you have oversized, then we cut it and we try to overlap the two ends of it. You sort of a pinch and we place a V cut and we cut it just approximately to overlap one another and we spot weld it and fit it on. Sometimes open contacts are there. Large selection of large size crown. You always have to give a very important that you take a larger size crown and you give an exaggerated interproximal contour so that it fits well. Evaluation and follow-up. Now, as we give stainless steel crown, we never tend to follow it up. So what is that follow-up mechanism which we need to have in every patient? Whenever we give crown, when they come for the further follow-up checkups, crown retention, present or absent, that the crown is there or not. Take a customized modified gingival index 0, 1, 2, 3, ranging from healthy to severe, plaque index 0 to 3, gingival margin extension, occlusion, alignment related to arch form, and lastly, proximal contact. So these are areas you just say, where you can politely tell the patient, yeah, this is the follow-up and this is how it is, and it makes it more appealing that you are following it even the prosthetic component which you have placed in the patient's mouth. Now, there are a lot of studies on just stainless steel crowns and gingival health, 2004, 2014. Definitely all gingival index score, probing depth. We have the problem which I have seen kids is they just take the burr and molong bleeding and in that very bloody what do you call saliva. Then the whole thing and the patient is working and it looks anesthetic. It looks a scary atmosphere. So please respect the gingiva. What are the clinical complications which I have seen when students are learning is interproximal ledges are something which is created or the crown is tilted, poor margins, then there's a chance of aspiration as well as ingestion. So what are the reasons why it can happen in interproximal ledges because of incorrect angulation of the tapered pressure bar, especially the proximal surfaces, extend the proximal slice below the gingival crest. Why the crown tilt? Because deficient lingual or buccal walls are improper, so the tooth it automatically looks like the occlusal table is tilted downwards. So don't try to reduce the quantum of core buildup. That is you have to do a proper core buildup. Then the table will be straight and you can have the crown seated straight. Poor margins, improper adaptation, keep margins apical to the greatest diameter, recrimp open margins. Sometimes whatever ingestion or aspiration, definitely foreign body, keep patient. This is the reverse Trendelenburg position. No airway obstruction notice if it's symptomatic. Then if it's no airway obstruction, scrutinize oral cavity, definitely check for what has happened to ingestion or aspiration. If object is found in the oral cavity, retrieve, modify and confirm the object, reassure the patient. However, if it is inside, then monitor airway, escort patient to a medical emergency for clinical and radiographic examination. Now, airway obstruction, ask a patient to cough. Try to regurgitate the inhaled object to clear airway. Attempt dislodgement with repeated back blows. If object still maintains impacted and airway, attempt Heimlich maneuver to relieve obstruction. Object dislodged, retrieve, identify, confirm the object, reassure the patient. But object not dislodged, immediately summon help and escort patient to medical expert emergency unit. So many literature reviews, wonderful. Stainless steel crown is one of the finest against the zirconia. We have compared so many things with zirconia, though aesthetics do matter, but it has its own advantages. So one of the most preferred type of rehabilitation for the post-endo restorations of primary tooth. Now, it was Hall's technique. Dr. Harna Hall, Scotland, he introduced the quick and non-invasive technique. Most important is sufficient soft tissue, sound tissue, sorry, not soft tissue, sound tissue left to retain the crown, class 1 lesion, class 2 lesions, and no signs of any clinical signs of pulpal involvement. Any kind of involvement of pulp, any pulpal exposure, pathologies, crowns are broken down with caries, bacterial endocarditis, any cases, definitely it's contraindicated. The crown is seated over the tooth without any local anesthesia or caries removal. Definitely we need a proximal space to the crown, definitely place a separator. Whatever crown fits this particular thing, select, adjust the crown accordingly, and cement the ground, followed by excessive use of floss. Literature reviews has said that survival rate of SSC was 73% and 68 after 5 years. Difference between survival rate of Hall's and traditional technique was clinically insignificant after 1 year. This is one of the finest, if you ask me, just as a guidance, it's nowadays various companies in India are manufacturing stainless steel crown. From the practice perspective, it takes around 20 minutes to do a crown. Your charges are good. So definitely it's one of the financial exercises which makes you more independent. But definitely to conclude, you're still the one. You'll always be the one we love. That's something which I always thought for stainless steel crown, because those zirconia crowns, so many crowns which have come into the market, but encompassing other than aesthetics, it has got features which every pediatric dentist will love to have do. And this procedure is not cumbersome, but it's beautiful. So I feel that this crown needs to be respected the most when it comes to pediatric dentistry. Thank you so much for the patient sharing. Any questions I would love to take. Thank you so much, ISPPD, also for giving me this opportunity.
Manoj, bolo. I'm unable to hear you. Sure. It's a lot of questions. Ask me 5 questions, rest we can mail. Yeah. Yes, Manoj. I'm unable to hear you. You can hear me, Manoj?
Yes, sir. Yes, sir. Sorry, sir.
Yeah, please. You are muted.
Difference between micro and macro crimping.
Crimping is crimping. I don't think so. There's something called as micro crimping. See, macro is you take a larger one. The smaller one could be the most edge of the stainless steel crown. I think that should be micro crimping. Nothing much. Crimping is a crimping procedure.
What is reverse crimping? I mean, there are a lot of
reverse crimping. What is there to do reverse crimping? I think crimping is one procedure which holds on to the cement and the crown as well as on the tooth. That should be fine. I'll go through some newer exercise, newer terminologies like reverse crimping needs to be analyzed.
Sir, ideal way to sterilize the stainless steel crown. This is the questions that PG has asked for their chairside viva. I mean,
see, I think if you ask me about sterilizing stainless steel crown, first thing is it's very important because stabilizing the crowns while trimming is one Herculean task. And how much ever you sterilize with stainless steel crown with any autoclaving methodology or whatever, I think it tends to fall. That's something which you always we have seen with stainless steel crowns. I think we always have chair side spirit to clean it up, and because that tends to fall because it's a slippery glove as well as the trimming portion. and the trimming also a little bit gets heated up with the crown. So if it falls or something, then you can use a normal spirit. That should be fine.
Sir, all stainless steel crown need finishing or alteration needed crown only needs crown finishing? I didn't understand this question properly. I mean,
What? I didn't get it. Sorry.
all the stainless steel crown need finishing or any alteration needed crowns?
No, any crowns for that matter need finishing. Very important. You just know you can't ignore gingiva here. So you need to polish and place it. You should not make a place for a plaque accumulation.
The other question is how to select the crown, exactly the crown dimension digitally.
I think, yeah, I have mentioned the
Yeah.
convention. Yeah, if you look at the theoretical aspect of it, though there are so many vernier calipers and some measurements which we take from inside we measure the mesodistal dimension. But as a practitioner, I still feel, or anybody, we should not look into that only measurements. Preferably, we should have always one size lesser and one size bigger, just in your inventory to make sure that you are safe.
The another question is very important. What are the different methods by which we can prevent the accidental aspiration of stainless steel crown by child?
See, if you look at it, rubber dam is a very good alternative. Rubber dam is a very good alternative, but
Yes.
because see, at the end of the day, that's the reason. Sometimes I see now all of them. We always have thought that rubber dam is a cumbersome exercises because we don't tend to use it in our day-to-day practice. Probably, if at all you know that it can be used in the best way, then there's nothing to worry about. But yeah, we have to take care. We have to take our precautions if at all we are not using rubber dam. It's not like we tie some floss. There's no way mechanism in which we can stabilize that.
So we can use a torque weld with the help of floss also. I mean, that is another way of doing that.
Yeah, floss is something. Yeah, that's what I was telling. Yeah, floss is something which.
Rubber dam.
Yes.
Yes. Sir, there is another question.
Anything else?
In treating a child under general anesthesia, we go for a. Yes, sir, there is one question. Treating a child under general anesthesia, we go for a passive fit of a stainless steel crown. Since we cannot check the occlusion properly, won't it dislodge? I mean, this is the question asked by PG.
I think passive fit, though passive fit is there, but stabilization is with the cementation. So there should not be any problem with it.
So there are a lot of questions we can answer it.
Yeah, I think this is a clinical entity, and definitely it's something which requires a chairside demo, and then go ahead and ask brainstorming. A lot of questions do come in this. So
yes, sir.
I think if they want, you can pass on my mail address. Even I to
sure,
certain
sir,
extent, I have not done reverse crimping, though textbook says about it. So for some specialized cases which reverse crimping is used, what you do in a day-to-day practice is something which we always recollect and we need to know. When some specialized cases comes in, then definitely reverse crimping is something which I was analyzing it now. So probably we will study on that. But of course, stainless steel crown is very important, and you need to do whatever I have mentioned. In 95% of the cases, you have to follow the conventional steps.
Okay, so thank you, sir. Thank you for your wonderful presentation, sir. Can we have a certificate? I mean, just. So please accept this token.
Thank you so much.
From
thank
the
you, Dr. Manoj. Thank you.
Thank you, sir.
Yeah, thank you. Thank you so much.
Thank you, sir. Dr. Pavitra, I request Dr. Pavitra to introduce our next speaker.
Yes, sir. So next in line, we have our esteemed speaker, Dr. Subbalakshmi ma'am, to deliver a lecture on zirconia and other newer crowns in pediatric dentistry. So ma'am is currently a professor at Malabar Dental College with prior academic and administrative roles at Pushpagiri and Sri Ramachandra Institute. She had completed her MDS from Sri Ramachandra University and currently pursuing PhD in health professions, education with focus on technology-based learning. Ma'am is also an academician and clinician in pediatric dentistry with experience in reputed institutions, Smile Train programs, and extensive research collaborations. Active ISPPD Executive Committee member, journal editor, and CDE conveyor with strong relationship in academic organization. Ma'am has also authored publications, book chapters, and conference presentations, contributing significantly to dental education, research innovation, and faculty development initiatives. So with that, can we move on to the presentation, please?
Virtual Rapid Revision, Series 7, conducted by the Lead Society of Pediatric and Preventive Dentistry. I'm Dr. Subhalakshmi, and today, over the next 30 minutes, you're going to see a brief overview of different aesthetic crowns, particularly about zirconia and the newer aesthetic crowns which have been introduced in pediatric dentistry. This whole session of about 30 minutes is meant to be centered around, is meant to be a rapid rather than a class on zirconia crowns. So there are some important literature which you will have to know, and how to approach this answer in the exam. What I'm saying here are small tips and small ideas, but kindly please use your discretion. So what are we going to do today? We'll start with what is the rationale of using aesthetic crowns. Why we are going to be using aesthetics, the importance of aesthetics in the pediatric population. We'll also look at what are the different types of aesthetic crowns. Then we will look at all the zirconia crowns in pediatric dentistry in detail. A little bit about other aesthetic crowns which are there, which we use, and also some of the questions which have been asked in the exam and how we could approach to answering these questions. We all know that aesthetics is very important even to children, right? We know that to build a self-image and to have confidence. Basically they found that improving the color, the contour, the quality of compromised teeth can really change a child's self-image and improve social confidence. It also prevents negative consequences because having decayed or malformed teeth can really affect the self-esteem of a child in a very bad way. It's also been found that the peers, children as young as 3.5 to 4 year olds, accept their peers who have nice, well-formed and minds and good teeth. And also, another important thing is that when they have malformed or unpleasant appearance, they may not, be very happy to make friends with them, and this might have a long-term consequences on the child. Also, at a lot of times, we've seen that the parents often see frustrations which would, bring about their children's appearance in such a way that it is socially accepted, at school or in other settings. That's important. Of course, we all know the importance of phonetics and also for the eating, for which it is important. And of course, the societal emphasis is something that we have to keep in mind. And also the satisfaction that a parent feels when the treatment is done. So basically, if we look for the rationale for aesthetics, what else is there? We're looking at an aesthetic appeal. Yes, that's very important. We're also looking at the parental approval. And then one other important thing we're going to keep in our mind is biocompatibility. So remember this. Look at the few references that I've already given in the previous slide, and this systematic review may help you to answer this rationale and the reason why aesthetics is important for children. So now let us get into the topic proper. And if you look at anterior aesthetic restoration, the American Academy of Pediatric Dentistry says it includes pre-veneered stainless steel crowns, open face stainless steel crowns, strip crowns, and preformed zircon crowns. So then, if you look at how they are being classified, they're classified into two major headings: one by the mode of attachment as bonded and luted crowns, and the other by the material composition and design. So by material composition and design, they can be zirconia, they can be modified stainless steel crowns, resin composite crowns, polymer and thermoplastic crowns, and aluminum modified crowns. We look at each one of them now. So by mode of attachment, like I said, bonded crowns, the examples are strip crowns, pedo jacket crowns, the new millennium crowns, and the glass deck or art glass crowns. Fluted crowns include pre-veneered stainless steel crowns, zirconia crowns, polycarbonate crowns, open face stainless steel crowns, and pedo pearls. Then, when we classify the crown aesthetic crowns by material, we start with the zirconia crowns. Then we are looking at modified stainless steel crowns, and then we have got modified stainless steel crowns, maybe open face stainless steel crowns or pre-veneered stainless steel crowns. The resin composite crowns, in that, of course, the strip crowns, which are basically celluloid forms, which are filled with composite resin. Then we have something called as Figaro crowns. They are basically quartz and fiberglass crowns. Then we have the Edelweiss, which is reinforced composite, reinforced with barium glass. Then we have the pedo jacket crowns. Basically, they are a copolyester jacket, which needs to be filled with tooth, right? Then the polymer and thermoplastic crowns, we have the polycarbonate crowns, the peak crowns, and the bioflex crowns. Aluminium-based crowns is your pedo pearls, which have a veneer or a facing on them. So now we have looked at what is the reason for aesthetics, why we have to aesthetically restore teeth, and looked at what are the aesthetic restorations which are available, and we've also looked at the classification of different aesthetic crowns which are available. Next, we will move on to the indications and contraindications in general about aesthetic crowns. Then we will take each type of crown separately. So, the American Academy of Pediatric Dentistry, in their best practice or clinical recommendations, gives one single recommendation, or indication. It says whenever a stainless steel crown would otherwise be indicated, a zirconia crown may be considered in lieu of it due to aesthetic considerations. So more or less, it says that anywhere where we are going to use a preformed stainless steel crown, it would be okay to use a zirconia crown or a aesthetic restoration. So we will look at the general indications. It will include extensive carious lesions where restoring the teeth with rampant or multi-surface caries, especially those involving 3 or more surfaces where we are going to where a traditional filling may fail. Post-pulpectomy or pulpotomy procedures, to protect the weakened remaining tooth structure, a crown is indicated. Whenever we have developmental defects, especially something like enamel hyperplasia or hypomineralization or molar incisor hypomineralization or amyloidosis imperfecta or dentinosis imperfecta, again, we can use these crowns. These crowns are used following traumatic dental injuries to restore form and function. They are also used to maintain letting the tooth be in proper occlusion and to maintain masticatory efficiency phonetics. So I also keep the vertical dimension of the lower 1/3 of the face, and definitely for arch integrity when we use them as abutment for space maintainers or when we want to prevent any undesirable tooth migration. So are there any contraindications? Yes, probably when the tooth is non-restorable and when the teeth, can be restored by a conventional means. So I would at this point say that there's no absolute contraindication for placing a aesthetic restoration. But in certain situations, certain type of aesthetic restorations may not be indicated. So these are relative contraindications that we should keep in our mind when we are giving a planning for a aesthetic restoration. For example, when there is a gingival inflammation which is there, or in a child who is a severe bruxer, we are not going to be giving a strip crown or a zirconia crown or a polycarbonate crown. In that condition, probably a pre-veneered stainless steel crown or an aluminium veneered crown would be a good choice. But given a condition where there's going to be crowding of the anterior teeth, I don't think we are going to be able to give a successful bioflex or zirconia or even a preveneal crown. A strip crown could be a good choice of restoration in those conditions. And whenever we have gingival inflammation, again, a stainless steel crown would be one of the best choices. A preveneered or an aluminum veneered crown would be a good choice in that case, and also in the case of bruxism. So remember these relative contraindications when we give plan for aesthetic restoration. So having talked a little bit in general about aesthetic restorations and aesthetic crowns, let's move into zirconia crowns in pediatric dentistry. This topic, we will be looking at the zirconia, the material, the composition of the crowns, what are the different types of crowns which are there, the indications, the tooth preparation, how we cement them, clinical success, and a few of the commercially available zirconia crowns. Let's understand that zirconia is an inorganic metal oxide which is basically used in ceramic materials. It has mechanical properties which are very similar to metal. The thing about zirconia crowns is they cannot be manipulated with crimping or contouring, and they require a very passive fit because of this reason. So this also leads to an extensive tooth structure reduction which is required when we are placing zirconia crowns, which we will read about in the subsequent slides. So zirconia crowns in pediatric dentistry were introduced in 2008 by John P. Hansen and Jeffrey Fisher. It has demonstrated high wear resistance, excellent biocompatibility, and superior corrosion resistant. Basically, three types of zirconia are currently used in dentistry. One is the tria-stabilized tetragonal zirconia polycrystals. The next is the magnesia partially stabilized zirconia, and the zirconia which is toughened alumina. Right? So, zirconia, why is it so much in demand, or why are its properties? Is mainly because of this unique ability of zirconia to be able to transform from one crystalline phase to the another. So because of which there is a resultant increase in the volume. So, and this stops the crack from propagating, because of which the zirconia is able to resist any cracks on it and has such good strength properties. So it moves in different phases. Right? So we will have to remember this, that it is able to transform from one crystalline phase to the another. Right? So we'll have to remember. Then moving on to surface characteristics, zirconia is well glazed and polished. So it has it's inert, it's highly polished, and this is a critical composition because of this reason, it discourages bacterialization and plaque accumulation. This also reduces the abrasiveness of the material against the opposing natural tooth. The next surface characteristic that's very important to us is that it is non-porous, and this non-porousness or non-porous nature of the material makes it superior. Its property of color stability very superior. It does not allow for any absorption of dietary stains because it is non-porous. So these are the couple of facts that we will have to remember about the surface characteristics of zirconia crowns. So this slide has the composition of zirconia crowns which are used in pediatric dentistry. I think it is important that you should be aware of this, especially in case it is going to be a recent advance, as I say, or otherwise. So basically, from 70 to 96% or to 100% is zirconium oxide. Then we already looked at yttrium oxide, which is present. Sometimes it is alumina, which is present. In most of the commercially available pediatric dentistry preformed crowns, it's yttrium oxide which is there. That's about 4 to 5% in different crowns. And then there is an organic binder which is about 2% or always less than about 5%. So sometimes aluminium silicate glass or boron silicate glass is available but again less than 1% is what it is present. So the main composition, remember, zirconium oxide. Zirconia crowns are basically two types. One is a monolithic crown and the other is a layered veneered crown. Monolithic crowns are basically meaning they are milled from a single solid block of zirconia. Because of this design, it eliminates the risk of veneer chipping or delamination, which can occur with layered ceramic crowns. Layered or and densely sintered microstructure. This monolithic crowns have a densely sintered microstructure. Okay. Then the other is the layered veneered or sintered crowns. Here, what happens is the zirconia is formed by multiple layers which are sintered together. This resists crack propagation, about which we have already spoken about. And this also ensures that there is no chemical degradation, right? So remember this, and yttria stabilized tetragonal zirconia polycrystal 5YTZP. Please do remember this material. That is one which is specifically used in metric dentistry, which has this unique feature of resisting crack propagation. So, what are the indications of zirconia crown beyond what we have already discussed? Remember, when we have a maximum aesthetic demand, highest level of natural appearance is required. When the patient has, high caries, so the zirconia smooth surface is really going to help in these conditions. Then again, zirconia is a good choice. Also, for patients who have allergy to any kind of metals, this is a very safe choice, especially nickel allergy, because most of our preformed other metals as crowns have the nickel found in them. Also, when there is going to be the need for crown for a longer duration, especially in the posterior region where high masticatory forces are present. So next we will move on to preparation for zirconia crowns. Remember, the rubber dam isolation is an ideal way of isolating the tooth for a zirconia crown. Next is when we will do the occlusal reduction. Up to 2 millimeter of occlusal reduction is required, because remember, zirconia crowns, unlike our stainless steel crowns, have bulk. So ensure that there is sufficient bulk for the rigid ceramic material to withstand masticatory forces without fracturing. So at least 2 millimeter of occlusal reduction is required. Then we go for a uniform circumferential reduction. Uniform circumferential reduction of from about 1 millimeter to 1.5 millimeters of the whole tooth structure is required. So the entire tooth has to be reduced by at least circumferential reduction of at least 1.5 millimeter is required. And also, this preparation should be slightly tapered towards the occlusal to allow for the crown to slide on. So, and when the finish line, it must include a smooth, continuous finish line, which could be a chamfer or a shoulder, and which is slightly below the gingival margin. So remember, it's going to be slightly below the gingival margin, and we avoid a feather edge finish, because this feather edge finishes can lead to poor marginal adaptation, or they can cause brittle fracture of the ceramic. So remember, very grossly, these are the three things that we should remember. Occlusal reduction of up to 1.5 to 2 millimeters, circumferential reduction of about 1.5 to 1.5 millimeters, and a finish line which is a little subgingival, which is either chamfer or shoulder. Other things that we should keep in mind when we are preparing for a zirconia crown, that it is a non-flexible crown. So the preparation must be completely free of any undercuts. Unlike that snap fit of the stainless steel crowns or preformed crowns that we are used to, this has to very passively fit on to the tooth. So remember, all undercuts will have to be eliminated. Any remaining bulge which will be there will prevent the crown from seating fully. Also, all internal line angles and sharp edges must be thoroughly rounded. Any sharp angles could cause for stress concentrations, which could lead for crown failure. Again, also any sharp angles might interfere with the passive fit of the crown. Next is sizing and trial fit. We have pink color specialized trial crowns which are available. So make sure that you select the crown based on the mesiodistal width of the tooth, and then adjust it. You will have to adjust the tooth to the crown because the crown cannot be adjusted. So ensure a trial fit in such a way that it is passive and fully seated before you can go ahead and cement it. Right? While cementation, the internal surface of the crown may be pre-treated by, example by sandblasting or by the manufacturer, which should help in enhancing bonding. They usually use RMGIC or resin cement, using which the crown is firmly cemented. So these are the steps in tooth preparation, which is there around 1 to 1.5 to 2 millimeters of occlusal reduction, circumferential reduction of 1 to 1.5 millimeters, and we reduce we place the crown subgingivally about 0.5 millimeters to 1 millimeter subgingivally with a shoulder chamfer finish. Some of the brands have a pink zirconia tri-in color crown. It is the same size and everything as that of the zirconia crown. Only thing is it is made from an autoclavable and reusable material. So this can be so that we do not contaminate the original crowns when we are preparing or trying the crowns. Next is the cementation options which are available for zirconia crowns. Glass ionomer cement, resin modified glass ionomer cements are the most common choice in pediatric dentistry because it balances between adequate bond strength and the fluoride release which is there, ease of use, and the degree of moisture tolerance that it has, especially when compared to resin cements. That's the reason why we prefer it. But the self-adhesive resin systems, when maximum retention is required, because definitely they offer better mechanical bonds. But they are very technique sensitive and require good isolation protocol. So remember that. We also can use bioactive cements, which are, there has been some work with these bioactive cements which are happening. And a conventional glass ionomers may be sometimes used, though it is not very ideal because it provides lower bond strength, right? So what are the steps in cementation? First is trial fit is a must. You should have a passive, fully seated fit. And if it does not, we will have to reduce the tooth further. Remember, we will not be able to do anything to the crown. So we're going to reduce the crown further. Then the internal surface pre-treatment, but this is something which is done by the manufacturer, like textured grooves or sandblasting is done. Then good isolation and moisture control, especially if you're using resin-based cements. Then the crown is seated with a firm and steady pressure. Any excess material must be meticulously removed from the gingival margin, of course, to prevent any irritation or inflammation which can occur there. So these are some of the literature which is available on cementation. I shall be sharing a PDF of this so you will be able to see it from there. So remember, the best self-adhesive resin for zirconia is MDP, especially when used in a combination with sandblasting. So let's look at some of the advantages of zirconia. One is definitely high in the aesthetics, superior durability, and you can actually place them a little more easier than a composite restoration, especially a strip crown. But remember, some of the disadvantages include it requires more time to prepare the tooth. Because we're going to place the margin subgingivally, there can be bleeding from the crown, from the gums, and then you're not going to be able to adjust the crown, so you will have to prepare the tooth, and maybe because of inflammation, which is there, or because of not great isolation, the cement and the zirconia may not bond too well, especially in children where isolation is going to be difficult. So these are some of the disadvantages of zirconia crowns. Let us look at the success rate or retention of these crowns. They have a retention rate of about 95 to 100% in 12 to 18 months, which is much, much higher than composite crowns, strip crowns, which are somewhere between 46 to 80%. And it is the retention of these crowns are better on vital teeth than pulpotomized teeth. And use of RMGIC has been associated with lower stress distribution, especially in simulated models. It has shown a long-term success survival rate of about 92% when it has been followed up for up to 6 years. And one of the most frequent cause of failure is debonding or loss of retention it can be due to either errors in tooth preparation or because of the cementation technique. So this is one study which I would recommend for you to read for and quote for clinical success of zirconia crowns. Some of the other crowns, other studies or systematic reviews which are there on zirconia crowns for primary teeth, which you could definitely go through when you're preparing. So what are some of the commercial pediatric zirconia crowns which are available? Zirkis, EZ, Kinder Crown, New Smile, Schenk, Sprague, and there are a few more new crowns which are available in zirconia crowns. Zirkis uses a very minimally invasive technique and it has superior aesthetics. And here the circumferential reduction about 0.5 to 1 millimeter is enough because it is slightly thinner. But again, remember, we need a small occlusal tapering which is required, which should be parallel both on the mesial and distal walls, and the preparation should be about 1 to 2 millimeters subgingivally for this crowns. These pedo crowns were basically developed. They were basically monolithic zirconia pedo crowns. Both anterior and posterior are there. They have a hint of a natural color, so they're very smooth, shiny, and they do not stain. We already looked at why they are non-porous, because of which they do not stain easily. So again, tooth preparation for EZ is very similar to that of stainless steel crown. It requires minimal reduction, but again, it is subgingival. One big advantage of EZ crowns is the Zirlock technology, or where the internal surface area for bonding is increased because it's got a sandblasted internal surface which is there. And it also has a very glazed facial surface which is very aesthetic, and it has a very low wear which it has exhibited. Also, it is autoclavable. So remember that about easy crowns. The next commercially available crowns is the Kinder crowns, which are available in natural shades, and they are available both as anterior and posterior crowns. So they have something called as incisor lock, which is a trademarked patented technology, where there is an optimal union of bonding between, and mechanical retention is also there. So instead of sandblasting, they have this incisor lock trademark technology. And it has a polishing system which is provided. So, we can have a microscopically scratch-free surface which minimizes any kind of wear on the opposing tooth which is present there. So it's highly polished, and it has, it is a scratch-free surface which is available. These crowns are available, Kinder crowns are available for both anterior and posterior teeth from sizes 1 to 6 for both the primary first and second molars. And in one pedo shade 1 and shade 2. The shade 2 is a more natural shade, and pedo 1 is a little more whiter shade which is used. The other zirconia crown is the New Smile ZR or zirconia crown. Again, a monolithic crown, and it is anatomically adjusted to a tooth and very gingival friendly because it resists any plaque formation. Of course, like all other zirconia crowns, this also has a color stability. But remember, this requires significantly more tooth reduction than other crowns, and it has shown a good 95% retention rate at 12 months and a very high marginal integrity, 90% in incisors and about 76% in molars. So far, again, another article which I would recommend that you read systematic review on zirconia crowns for primary teeth. So we will move on to the other aesthetic crowns. So some of the newer aesthetic crowns which are there are the new millennium crowns. They are basically composite material that is enhanced in the lab, very similar to our pedo jacket or strip crowns. They can be finished or reshaped with a high-speed finishing curve, but they are very brittle and they are more expensive than the others. And of course, these crowns cannot be crimped. Right? Like I said, they are more expensive and cannot be crimped, and they have the potential to irritate gingival tissues. So these are probably we can use them when we have a short-term aesthetic performances indicated, and they show very low survival rates. Pedo jacket crowns are made up of tooth-colored polyester material and is filled with resin material. It is left on the tooth after polymerization. They can be easily trimmed with scissors, so that's one good thing, but you cannot use a burr to adjust them. They are thin, but interproximal wall is very strong, so they are actually an ideal restoration when adjacently, we want to reduce the amount of tooth reduction, then it is a good choice of crown. There's only one single shade which is available. Art glass crowns or glass tech crowns are basically polymer glass, which provides a very natural feel, and the bonding ability is associated with composites and aesthetics. It's a new multifunctional methacrylate 3D molecular networks with a highly cross-linked structure, because of which has about 75% of fillers, 55% microglass, and 20% of silica filler, which is there. So it's pretty strong, and it is available in 6 sizes for every primary tooth and a single shade. It has good longevity also when compared to porcelains also. It has a dual advantage because bondability and feel of composite resins is combined with the longevity and aesthetics. Great durability, high fracture strength due to cross-link structure, and so much of fillers which is present in it, up to 50 to 60%. Has a highly polished surface which leads to reduced plaque accumulation. The longevity of these crowns is more than stick crowns, and once again, excellent aesthetics, superior color stability, high strength, and very conveniently repairable because you can repair them if damage occurs with composite. Only thing, they are very technique sensitive like other bonded restorations, because especially when we are working with children. The other set of crowns that we're going to be talking about is pedo pearls, which is a modification of traditional metal crowns which are used to improve appearance, and they're fabricated from aluminium rather than stainless steel. So there is a coating which is on the tooth, which is of the tooth color. It's an epoxy paint. So here aluminium is used because the epoxy coating adheres much better to it than stainless steel crown. Because it is aluminium, it is highly malleable and very soft, easy to cut and crimp, and the epoxy has shown to have a good bonding to aluminium. But we will not be able to use these crowns when there is in areas of heavy occlusion, and these require much lesser tooth preparation when compared to zirconia. So they are, of course, rooted restorations, like how we have understood. They are similar to single steel crown, but made with aluminium. Again, low cost is an advantage, ease of adaptation, and versatility. Only thing is, there have been very few times when areas where there has been a coating loss. The Figaro crowns, which were introduced in 2017, are basically fiberglass or quartz fibers which are embedded within a composite resin matrix. they have something called as the FlexFit technology. Basically, it's a unique feature that allows the material to adapt over an anatomic cervical convexity of the primary molars. So the undercut issue is not going to be a problem. The bulky molars is not going to be a problem with these crowns. They also have an anti-biofilm characteristics. So, because basically they have a lower surface roughness, and this makes it hydrophobic. So it deters any microbial colonization, specifically that of Streptococcus mutans. These crowns are biocompatible and are capable of withstanding autoclave sterilization. But one issue that we have with Figaro crowns is poor radiographic visibility, especially. So for us to monitor it on radiographs is difficult. One relative contraindication is the susceptibility to occlusal wear, because of which we could call it a relative contraindication. They are less suitable when children have severe bruxism or where there is a high stress occlusal environment. The tooth preparation requires minimal tooth preparation, very conservative preparation which is required, and they are cemented with GIC or RMGIC, but longevity is questionable because they are prone to structural failures, right? And the next set of crowns is the Edelweiss crowns, which was introduced in 2018. They are densely filled composite material which has been reinforced with their layers sintered with barium glass. The properties include good biocompatibility, good biofunctionality, especially for a primary tooth. There are, of course, plaque resistant and antibacterial properties which are there because of its surface characteristics like glossy finish and less porousness. But radiopacity again is limited. So monitoring with X-rays is a challenge, and they can be very easily repaired because intraorally they can be repaired with composite materials. The tooth preparation is very similar and less, but cementation, there is a bonding protocol. There needs to be an internal roughening, which needs to be slightly roughened, then be etch and bond and loop with composite luting material. We have to make sure that there is very less bleeding, which should be there when we are placing these Edelweiss crowns. Then they have all the advantages of the regular crowns. They are available in 3 sizes, small, medium, and large. And they mimic the natural dentition, very minimally invasive. But the disadvantages, it is relatively costly, technique sensitive because of the composite which is used, so which would make it a little time consuming. And of course, radiographic follow-up is a challenge. And then we have the BioFlex crowns, which are made from high-impact biocompatible hybrid resin polymer. They are metal-free and bis-GMA-free. They are a good choice for children who have nickel allergy. They also have the FlexFit adaptation, which is a self-adaptation mechanism. So what happens is they form a temporary dimple at high occlusal points rather than wearing down irreversibly. So their radiopacity is equivalent to natural tooth. So they can be followed up with radiographs over time. They laser marked and sandblasted on the internal surface. So this enhances micromechanical retention with luting cements. Tooth preparation they need a little more reduction than stainless steel crown, but more conservative than what is required for a zirconia crown. And the preparation involves uniform circumferential occlusal reduction to allow a very passive fit. They cannot be trimmed or crimped in the chair side. Remember that. And usually spitted with GIC or resin modified GIC, or we can use self-adhesive resin cements. Advantages: superior aesthetics, reduced chair side time, biocompatible, hypoallergic, which is a very, very good advantage. Of course, disadvantage that they have some staining and lower retention rates than stainless steel crowns, and there has been reported surface loss which is being seen. Retention rates are good. They've shown good longevity, but limited number of studies are available because these crowns have been introduced very late. But failure rates so far have been much lesser, up to about almost 6 to 7% in about 1 year follow-up studies. And before the last set of crowns that we will discuss is biology crowns, which is basically a technique which we use a fragment reattachment using natural tooth. So a naturally exfoliated tooth is hollowed out, and we use this as a biologic crown. This was first published as a case report in 1964 by Chesak, and they can be made from fragments of natural teeth. So these are the steps by which we are going to naturally biological crown is prepared. So, and I urge that you go through these couple of articles on biologic restoration in pediatric dentistry when you prepare for this answer. So and now we've spoken about all the crowns. In short, we'll also look at how these aesthetic crowns, what are the frequently asked questions. Strip crowns have been asked, zirconia crowns have been asked. These are usually asked in the recent advances paper. It's also asked in the clinical pediatric dentistry paper. And you can expect a recent advances paper on anterior aesthetic crowns. So when you're preparing for this, remember for each crown to write a short introduction which will talk about the importance of aesthetics, then talk about the composition or the material with which each one of these crowns are made. Remember the most important properties of these crowns, especially remember the trademarked property that each one of the crown has. Remember the general indication, contraindication, and specific relative contraindications of different crowns. Tooth preparation, though in general is very similar, remember the small, minute differences between tooth preparation for each one of these crowns, cementation, and you should remember at least one or two longevity studies and success rates of these crowns. Having said all this, I would like to conclude by saying a postgraduate exam is not a test of mere memory, but an evaluation of your ability to build and present a very scientific argument. So I'm sure these two tables that I'm putting here now will help you. I will be sharing a PDF of this presentation and the others. So please do go through these two tables. I'm very sure these tables will help you to present a very good argument in terms of zirconia and other newer crowns, which are now aesthetic crowns, which are now available in pediatric dentistry. Grateful, thankful, and blessed. Thank you to Team PGI and also to the Indian Society of Pediatric and Preventive Dentistry for this opportunity to have shared my thoughts with the exam postgraduates. To all the exam going postgraduates, all the very best to your preparation and the exam well. As always, I'd like to end by saying, let us not stop at shaping smiles. Let us shape some lives too in whatever ways that we can. So you can reach me on my mobile, on WhatsApp, or on my email ID. Once again, all the very best and thank you.
Thank you so much, ma'am, for such a wonderful presentation. Can we have the certificate?
Thank you. I have emailed all the articles and the PDF to the organizers. I'm sure they will send it across to everyone. I was not able to share everything here, so I've shared it with the team. They'll send it to you. Thank you for the opportunity again.
This is the certificate of appreciation. Thank you for your valuable time, ma'am.
Thank you. Thank you so much.
Now we move on to the last session. Here we have an esteemed speaker, Dr. Nilesh Rathi sir, who did his MDS from Kotiwal Dental College, Moradabad. Sir has also done PhD and FPO from Sharad Pawar Dental College, Varga. He has received prestigious Big Bharat Startup Grant. Sir also has more than 98 indexed publications, 5 chapters in the textbooks, IPRs such as copyrights and design registration. Sir's area of interest include implants in pediatric dentistry, digital pediatric dentistry, pediatric endodontics, and artificial intelligence in dentistry. So can we have the presentation, please?
Hello everyone, I am Dr. Nilesh Rathi from Dr. T.Y. Patil Dental College and Hospital, Pune. Today we will have a brief presentation on biomimetics materials in pediatric dentistry. Before starting with the presentation, I extend my warm greetings from Dr. T.Y. Patil Dental College. Now, what is biomimetics? Biomimetics is nothing but a study of formation, structure, or function of biologically produced substances and materials, and its mechanism or processes, especially for the purposes of synthesizing similar products by artificial mechanism which mimics the natural ones. To simplify this term, I'll put forth an example of a pneumatic heart. This is an artificial pneumatic heart which functions like a natural heart. So what exactly it is? It is biomimetics. It means if we speak the word biomimetics, it is study of lively tissue and a technology by which we can mimic this lively tissue. The classification given for biomimetics is given by Lamia Singer, and he has divided this biomimetics into two categories. First is biomimetics in restorative dentistry, and the other is biomimetics in regenerative dentistry. So, as we have biomimetics in the restorative dentistry, it is divided into two categories, that is restorative treatment approaches, and other is biomimetic restorative materials. In restorative treatment approaches, we have conventional extensive approaches and we have biomimetic conservative approaches. In second category of biomimetic restorative materials, we have materials, composites, and ceramics. In the second category, this is about biomimetic regenerative dentistry. This is divided into two categories, that is about dentin mineralization, and the other category is dentin pulp complex regeneration. So coming to the first part is about the difference between the conventional as well as the biomimetic approach. If you see here, the conventional approach is following the GP Black principle of removal of the caries as well as removal of the uninfected to substance for retention of the restorative material. But with the advent of adhesive dentistry, now we remove only caries portion and we maintain the healthy structure of the tooth. So with the advent of composites and GIC, we are resorting to have lesser removal of tooth so that the life of the tooth is increased. But there are two special protocols that needs to be followed in case of biomimetic approach, or it can also be called as minimal invasive dentistry. Those two protocols are stress reducing protocols and bond maximizing protocols. The first thing that needs to be learned here is biomimetic protocol for stress reduction. Any composite, when it's taken in a bulk, always have shrinkage, and we need to dissipate this shrinkage. The ideal method of reducing this shrinkage is only possible when you use indirect restorations. So, indirect restoration means either using onlay, inlay, and overlay. The care should be excised that we should never ever have composite thickness of more than 2 mm if you are not using a bulk fill composite. Any resin will always have polymerization shrinkage on curing. So the shrinkage can only be minimized when you use fiber reinforced composites. The addition of fibers to the composite with slow polymerization method will always help us to reduce the shrinkage of the composite restoration. The shrinkage of the composite restoration will also cause a kind of nano leakage by creating a nano gap. To overcome that nano gap, we always need to have a layer of flowable composite in the dentinal area. This layer of dentinal composite will always compensate for the shrinkage of the composite. The use of dual core composite and removal of the dental clad at 2 mm of the DJ junction will always help us to strengthen the composite restoration. Apart from the solo composite restoration, we also need to think about the occlusion stress. To relieve the occlusion stresses in the posterior region, it is more important to create a canine-guided occlusion. This canine-guided occlusion is created by create a favorable contact at the parietal fossa of the maxillary canine and the buccal surface of the mandibular canine. This contact should always be prepared bilaterally so that the occlusion forces on anterior and the posterior tooth can be balanced and we can create a healthy occlusion. After completing the stress reducing activity of biomimetic protocol, the second is bond maximizing protocol. The bond maximizing protocol suggests how to increase the bonding strength of a adhesive restorative material, especially the resin. So the most important thing is to create a peripheral seal zone. Peripheral seal zone means that around the restoration of the composite, there should not be any caries or crack. The occurrence of caries and crack will create a fault line and will cause fracture of the restoration. If suppose the restoration is fractured, then it should not be removed completely. Rather, it should be repaired by adding bonding agent or silent coupling agent over the existing restoration. All of us are aware that creation of MMPs in the dentin causes the destruction of the hybrid layer of the composite restoration. To increase the life of composite restoration, we should use chlorhexidine, which is having anti-MMP action so that it can maintain the life of the hybrid layer. Enamel beveling also helps us to increase the bonding surface area of the composite restoration. So beveling with a fine burr at the enamel helps us to increase the life of the composite. The life of the composite is also increased when we use dentin bonding agent, and especially in cases of immediate dentin seal. Now, immediate dentin seal is an important concept which should be considered in cases of indirect restoration. After preparation of the tooth, the dentin is exposed to the external environment and it will desiccate, and the desiccation of dentin will cause the failure or the collapse of the collagen bundle. To maintain that collagen bundle and avoid the infiltration of the bacteria, it is advisable to apply the dentin bonding agent immediately after the preparation. This will help us to maintain the moisture of the dentin, maintain the structure of the collagen, and have a good hybrid layer formation in the dental area. A coat of flowable composite will also help us to maintain the compressibility of the composite restoration, which will be similar to the dentin structure which is maintained under a healthy enamel. The next most important thing which should be considered while restoration is deep margin elevation. Deep margin elevation is a concept which is applied whenever there is subgingival restoration. A cavity which is extending subgingivally cannot be restored properly. So a composite restoration, especially a flowable composite, is placed in the basal area or maybe floor area which is lying subgingivally, and it is restored until the margin or the floor is raised above the margin gingiva. So this is elevating the subgingival margin of the cavity to the supragingival margin. This is an important concept to increase the bonding strength of the composite restoration. There are various modifications in glass ionomer cement. Normally we use resin modified GIC, GIC with zirconia, amalgamous CR, GIC with nanoparticles, miracle mix, cements. But apart from that, many studies have been conducted by adding chlorhexidine, hydroxyapatite, fiberglass, vallisonite, nanosilver, and ACP, CPP. There are multiple combinations that I won't discuss in detail. But the most interesting thing that is coming in the field of composite is self-healing composite. this will also be termed as a smart material. Now, what exactly is self-healing composite? The composite is made out of resin matrix, and in that resin matrix, they have got Grubbs catalyst. So, whenever a crack is propagating in the composite, it will fracture the silica capsule containing the resin. As the fracture line is propagating through this capsule, the resin into it will be filling this gap of the crack. So as the crack is filled with the help of resin, then there is the propagation of the crack is interrupted. So this is how this will be termed as self-healing composite. So this is nothing but a silica capsule containing resin, and as soon as this resin comes in contact with this Grubbs catalyst, it will start its polymerization and self-healing activity comes into play. The other ceramics are also acting as a biomimetic material, like Activa. The Activa cement releases fluoride and calcium in ample amount. It is a bulk-filled resin and it is a good agent for remineralization. A ceramic coating around the implant also helps to have better osteointegration. But the most interesting thing that I see in the field of prosthodontics is the hybrid ceramic polymer infiltrated ceramic network. Onyx is a material by Vigo which contains zirconia filler in PMMA resin and gives us better strength and better aesthetics. The next classification suggests about the biomimetic in regenerative dentistry. So this is divided into two categories, that is dentine mineralization and dentine pulp complex regeneration. Dentine mineralization means it is the material which is required for repairing of the demineralized enamel and dentin. And whereas dentine pulp complex regeneration suggests that there are some bioactive materials which will help us for remineralization of enamel and dentin, and it comes in the contact of the pulp, which helps us to regenerate some amount of dentin in the pulp also. It can be related to the bioactive materials, that is regeneration of pulp. It is generation of secondary and tertiary dentine. And this next category comes as the cell homing strategies. So to summarize about the bioactive materials activity for repairing of the demineralized enamel and dentine, it is divided into two categories, that is crystalline growth, which is called as top to bottom. This method is applicable when there is slight demineralization of the structure. All of us know that dentine and enamel, both of them contains organic as well as inorganic tissue. So whenever there is some amount of loss of inorganic tissue and the tissue contains less amount of inorganic substance followed by good amount of organic substance, this category of crystalline growth will be helpful to repair such kind of dentine and enamel. So this is called as top to bottom remineralization. The other category suggests when there is extensive demineralization. So extensive demineralization means that there is significant amount of loss of inorganic structure, that is calcium and phosphorus, and along with that there is destruction of the organic matrix also. So when there is destruction of the organic matrix, it is difficult to remineralize the structure by adding only calcium and phosphorus along with any casein or other vehicle agent. So in this situation, we require different kind of proteins which will help us to first repair the organic structure, and then this will only help us to bond that material to the inorganic substance. So to elaborate on this topic, let me present an idea of remineralization. So what is remineralization? So remineralization is nothing but the deposition of calcium, phosphate and hydroxide ion in a structure, maybe tubule of dentine or the structure of enamels. It will be directly depositing over it and it will form a calcified structure. This is only possible when the organic structure is healthy and there is minimal loss of inorganic structure. So this method is called as top-down approach. It means directly the minerals are deposited over the demineralized area, and this will help us to again regain the ionic composition of enamel and dentate. But in structure, where the inorganic organic structure is lost, it is difficult to absorb or adsorb the new calcium and phosphate ions to form hydroxyapatite crystals. So in those situations, it is expected that you should have bottom-up approach. This bottom-up approach suggests that they will first repair this collagen bundle, and after repairing this collagen bundle, they will have bioactive inorganic substances like ACP or some amount of matrix like dentin matrix protein or dentin phosphorine, which acts as an adhesive. This adhesive will help to bond this ACP or calcium and phosphate ions over the collagen to cause remineralization. There are other bioactive materials which can directly be utilized for the top to bottom remineralization. So they are nano bioactive classes which contain sodium, calcium, magnesium, and phosphate, and which will later form hydroxide crystal. We have got ACP, that is enamelon, theobromine, which enhances the crystalline growth of the enamel, arginine bicarbonate, self-assembling peptide P114, and iontophoresis. There are more methods and materials which will help us to have remineralization. They are nano hydroxyapatite crystals, that is Novamin, a patented technology. So early occlusion of defect by nano hydroxyapatite crystal of size 20 nanometer will help us to have better condensation and adhesion of the enamel which has lost some amount of the inorganic substance. Then we have tricalcium phosphate, it can be in alpha or beta phase. Then we have CPP ACP, where casein acts as a media, a selective media which is pH dependent, and it releases calcium, zinc, manganese, and phosphorus ample for mineralization. Then we have sodium calcium phosphosilicate, xylitol, and calcium sucrose phos. Calcium sucrose phosphate contains ACP, TCP, and hydroxyapatite crystal, and it is a strong remineralizing agent. Coming to the next part, it is 2.1.2, which is non-collagenous protein analog. Non-collagenous protein analog means from bottom to top remineralization. So bottom to top remineralization means first we'll be repairing the collagen bundle, then we'll be having some amount of proteinous adhesive, which will help us to have adsorption or absorption of the calcium and phosphate ions. So polydopamine is one of the strongest adhesive which helps us for remineralization. It undergoes oxidation, and because of oxidation, it will form a polymerase dopamine, which is known as a biological glue. This glue works like a glue of bristle. This glue will join the collagen bundle and it will cause nucleation of hydroxyapatite crystal for early remineralization. So this is one of the most potent glue, biological glue, which will help for remineralization, and before remineralization, it will repair the organic structure. The second in the category is polyelectrolyte. So polyelectrolyte is nothing but a polymer, an ionic polymer, which when comes in contact with the water, will form electrolyte. This electrolyte basically is released, and this released electrolyte helps us to bond the calcium and phosphate in the intrafibrillar area and interfibrillar area. When this kind of addition of calcium and phosphate occurs in intrafibrillar and interfibrillar area, it helps us to mimic the enzyme called as dentin matrix protein 1 and dentin phosphoprotein. So this is a biomimetic action where polyvinyl phosphonic acid disperse the electrolyte, and this electrolyte will act as an enzyme which will help for remineralization, just like DMP1 and DBP enzymes in dentin. Next is polyamidoamine tetramer. Polyamidoamine tetramer also acts in the similar way. It is an artificial protein, and this protein has got micelles. This micelles attaches to the calcium and phosphate ions, and this attachment is then adhered over the intrafibrillar area of dentin. When this polyamidoamine attaches to the collagen bundle of dentin along with calcium and phosphate, the mineralization occurs, and this kind of mineralization has got better results. A similar kind of material that works on bottom to top mechanism, that is repairing the organic and then causing deposition of inorganic substance, is sodium trimetaphosphate. This sodium trimetaphosphate is nothing but also called as phosphophorine. This phosphophorine is nothing but a component of collagen. This produces negatively charged sites that attracts the nanohydroxyapatite crystals. In this way, it helps for early nucleation and then maturation of the mineralization. Coming to the next part is about bioactive material for pulp dentin complex. This is coming under the bioactive material for pulp dentin regeneration. So the pulp dentin regeneration, that is repairing of the dental tubules or repairing of the dentin, deeper portion of dentin near the pulp. We know that calcium hydroxide, MTA, pydentin, and MDOGATE has got good results for TPT, IPT, and pulpotomy. The next category is cell homing strategies. Now, what is cell homing strategies? Cell homing is the protocol or a strategy in which there is recruitment of stem cells or progenitor cells to achieve tissue regeneration. So it is a method by which you not only you deposit the growth factors or you deposit particular kind of enzymes which will help us for repairing the tissue. In the previous part of the presentation, we have talked only about the inorganic substance like calcium, phosphate, and its congener like MTA, biodentin, which were just trying to repair the hard tissue. Then we talked about the protein enzymes which helps to bind those, repair those collagen and bind those inorganic substances to the tissue. Here it is altogether a different thing. They are not trying to add something, but they are trying to propagate the growth by adding the growth factors or their progenitor cells. So the examples are platelet concentrate. So platelet concentrates are divided into two categories, that is PRP and PRF. So platelet-rich plasma releases growth factors for 2 to 4 days, whereas platelet-rich fibrin, it has got 6 to 7 growth factors, and those are released for at least 15 days. So they give a sustained release of growth factors that too at higher concentration, because growth factors are already polymerized in the collagen matrix. The next component is bone morphogenic protein. So bone morphogenic protein is the constituent of bone. This is also present in enamel, that is BMP4 and BMP5, and in dentin, BMP2, BMP4, BMP6, and BMP7. Addition of this BMP, this is enzyme, will always help us to repair the enamel and dentin. Hyaluronic acid and derivative. Hyaluronic acid is the integral composition of soft tissue. It always forms the basic structure of the connective tissue. So it has got an important role in maintaining the structure of the tissue. Influence of growth factors. It forms a matrix for regeneration and mineralization. Collagen. Collagen is the basic composition of connective tissue, and it is required to create a substrate for any growth or any repair. So it is a matrix for adhesion and attachment of stem cells. And it also creates a matrix for sending the signaling molecules for differentiation. Cell homing strategy, it was introduced in 2010 as a viable regenerative approach. It involves recruitment of stem cell progenitor cells and uses the biological signaling molecules for tissue regeneration, revascularization, and pulp healing. These are the other advancements in biomimetic scaffold. And nowadays we have got 3D printed PLA scaffold, and with which we can just home the cells, that is, we extract the cells and we place the cells in the matrix so that it can be transported or deposited in the particular area of interest. So these strategies have got promising results, and in near future you will see that they are used extensively. So to conclude, regeneration and repair assisted by the biological material is the best solution for ailments in human beings. It adds a new dimension for the long-term success of the treatment. These are the few FAQs that are asked in the examination. That is, classification of biomimetics, enumerate the biomimetics restorative materials in dentistry, write about the mechanism of silicate-based bioceramics, describe non-collagenous protein analogs for tooth repair, differentiate between various types of pulp protecting agents, and protocol for selection of the restorative material. With this, I complete my presentation. And if you have any doubts to clarify, you can reach as fast as this bullet train, which is inspired by this bird, the pecker. So these are my contact number and mail ID. You can reach out whenever it is required. Thank you.
Thank you so much, sir, for such an informative and insightful lecture. Any questions? If there are any questions, you can post it in the chat box immediately. All right.
I am ready to take the questions.
So right now there are no questions in the chat box, sir. If they put any question, we can address them later.
Yes, ma'am. At the outset, ma'am, I'm thankful to Dr. Vaindra Goel sir, Dr. Baliga sir, and Dr. Manoj Jaiswal for organizing this program meticulously.
Thank you, sir. Thanks a lot, sir. Thank you for your support, sir.
Thank you, sir.
Can we have the certificate, please? So please accept the certificate as a token of appreciation from the organizing team.
Thank you, ma'am.
Thank you, sir. So as we conclude day 1 of Rapid Revision 2026, I would like to sincerely thank all our esteemed speakers, faculty members, and enthusiastic participants for making today's session highly interactive and enriching. We look forward to welcoming you all again tomorrow for another exciting day of academic learning. Thank you and have a wonderful evening.
Thank you, ma'am.